everyone, I'm Dr. Ilajan Khandelwal, and now let us start with the next module from gastrointestinal tract, that is inflammatory bowel disease. This is one of the very important modules from the chapter of GIT students, must have been covered in medicine and surgery as well. Here I will focus more on the morphological aspect, but I can promise I'll also cover some of the clinical and surgical aspects, right? Now, if you're a second year student, then this is one of the most favorite topic for the examiners. Even in your practical exam, a specimen of a Crohn's disease or ulcerative colitis intestine is usually kept. And in your pre-prof and prof exam, you can get a long question on any of them, right? Then if you're a MCQ exam giving student, then this is one of the favorite topics from GIT. You get a lot of questions from this topic, and I'll try to cover all of them, right? And the kind of clinical pathologic scenarios which can be asked to you, I have discussed them in great detail at the end of this module. Shall we start our journey of inflammatory bowel disease? Okay, so the two inflammatory bowel disease which we are going to discuss in this module are the Crohn's disease and the ulcerative colitis. Crohn's disease and the ulcerative colitis, right? These diseases are much more common as compared in females as compared to males. Then they have a bimodal age distribution. That means usually one peak is around 15 to 20 years and the other peak is in elderly. That is an important point. They have a bimodal age distribution. And you must have noticed that these disorders are much more common in Western countries. In India, the incidence is also increasing now, but much more common in Western countries and Caucasians. Understood the basic epidemiology of the disease? Now let us move to the brief pathogenesis of disorder. Now, when I talk about the pathogenesis, they say that the etiology is not completely understood till now, but a few hypotheses have been given, in which the most acceptable hypothesis, they say, is the hygiene hypothesis. What does this hygiene hypothesis say? These days, we have a lot of food which is rich in preservatives, right? So they say the mucosal immunity is not properly developed, and because it is not properly developed, sometimes it can lead to the development of IBDs, inflammatory bowel disease. Understood? So, because of the lack of development of mucosal immunity, right, this disease can happen. But then this hypothesis is not confirmatory, right? Then students, there are a lot of genetic factors which have been implicated, in which a very popular genetic factor is NOD2 gene polymorphism. This is important. NOD2 gene polymorphism. Now, when there is a problem with the NOD2 gene, what it leads to? It leads to increased activation of the NFK beta pathway, right? You all know that NFK beta is the growth signaling pathway, right? So when it is activated, it will lead to increased cell proliferation. When these cells start proliferating, it leads to the development of IBDs. So this NOD2 gene polymorphism is quite important in the development of IBDs, right? The two other things which have been implicated are ATG16L1, very important student, autophagy related 16L1, very important. Remember in inflammation when we studied about autophagy, I told you that there is a gene called as autophagy related 16L1 which is implicated in the development of IBD. So this is some new data which has come up, so can be asked in your MCQ exams, right? Autophagy related 16L1. This is one gene which can be implicated. Then the next gene which can be implicated is IL-23 gene polymorphism. They say this IL-23 gene polymorphism has been considered to be protective. This is protective for both IBDs. That means both Crohn's disease and ulcerative colitis, this IL-23 gene polymorphism will be protective, right? Another gene which has been implicated is called as IRGM, that is immunity related GTPase M. Immunity-related GTPase M. This gene has also been implicated in the development of both the inflammatory bowel diseases. Understood the basic thing, right? Now let me go to my point, students, that is the morphology. Before we go to the morphology, students, what I want to tell you is some very basic information about Crohn's disease and ulcerative colitis. What is the most common site for Crohn's disease? The answer is ileum. This disease usually affects the ileum or the ileocecal valve, right? Or the cecum, correct? When I ask you what is the most common site of ulcerative colitis, the answer is going to be rectum. And from the rectum, it spreads upwards towards the colon. That is why this has got a retrograde spread. It has got a retrograde spread. Correct, easy? Then, a very important point is Crohn's disease is transmural. Trans means all, mural means layers. So, it involves all the layers of the gastrointestinal tract, that is the mucosa, submucosa, muscularis propria and adventitia. Whereas ulcerative colitis is submucosal. It will involve only till the submucosa, not below that, only till the submucosa. Understood? Easy story? Okay. This is the difference between Crohn's disease and ulcerative colitis, basic. And at the end of this module, I'll give you a very important and high-yield table of the important differences between both these disorders, right? Now, let us move to the morphology of Crohn's disease. Let me start with the basic morphology of Crohn's disease, correct? Now, first of all, let us see the gross appearances. Very important point, students. So the first thing which you can see is the development of aphthous ulcers. Robin says this is one of the most earliest lesions. Which is the earliest lesion to develop in a patient of Crohn's disease? Answer is aphthous ulcers, right? So suppose, students, this is the intestine. A lot of these ulcers will form, right? And these ulcers will coalesce with each other. Over time, they will start coalescing with each other, fusing with each other to form snake-like areas. So that is why these are called as serpentine or serpiginous ulcers. Serpentine ulcers or serpiginous ulcers. Another important point, right? So ulcers, they start coalescing with each other or fusing with each other. So over time, they will form this snake-like area, which is called as a serpentine ulcer. Understood? Easy story, students, right? Then you should know that what kind of ulcer is this? So in Crohn's disease, the ulcer is usually deep and knife-like. They are very deep ulcers, right? Why? Because there is transmural involvement, so it will involve all the layers. So they are deep knife-like ulcers. The second thing which I can see is called as skip lesions. Now, the very important thing which you have to remember is it is the most characteristic feature. If skip lesions are present, you definitely start thinking in terms of Crohn's disease. What do you mean by skip lesion? Suppose this is the intestine. So skip lesions, this is the lesion. Then a part of the intestine is normal. This is the lesion, then normal. Then this lesion, then normal. So that is why it is called as a skip lesion, right? The lesions are not continuous. They are skipped. Some area is normal and some area is defected. So these skip lesions are characteristic feature of Crohn's disease. Clear? Next. The next thing which we see is called as creeping fat. Creeping fat. What happens over time, the fat oozes out. The mesenteric fat will ooze out over the serosal surface. That is called as a creeping fat, right? So what is creeping fat? The mesenteric fat, it oozes out over the serosal surface. And then we call it as a creeping fat. A very important point. Right? Next, students, what else can you see? A very important thing which we see is called as cobblestone appearance of mucosa. cobblestone appearance of mucosa. So what happens, students? You have these ulcers and you have these skip lesions. So when you see the intestine, you have normal area and then you have ulcerated area. So you have these islands of regenerating mucosa which appear like a cobblestone. So the intestine gives this appearance just like this cobblestone. So this is called as the cobblestone appearance of mucosa, which can be seen because of the regeneration of the mucosa in between, right? Understood? Easy story. And the last thing which I can see is rubbery thick intestinal wall. Rubbery thick intestinal wall. Intestinal wall is very, very thick and rubbery. So let us quickly revise all the gross features of Crohn's disease. You will see skip lesions. That means lesions are not continuous. When these ulcers will coalesce, they will form deep knife-like ulcers which look like a snake. Then you will see creeping fat in which the fat will encircle the serosal surface. Then you will see cobblestone appearance of mucosa, something like this. Understood? Let me show you the images, students, so that you are much more clear. In this image, can you beautifully see this intestine? Now, when the surgeon opens this intestine, can you people see that there are these areas which are protruding just like a regenerating mucosa? They look like this appearance. These are cobblestones. So this is called as the cobblestone appearance of mucosa. Easy story, students. Now you will remember, I've seen a lot of these cases of inflammatory bowel disease in my posting in GB Pant Hospital. They used to get a lot of these inflammatory bowel disease, right? So the mucosa looks beautifully like a cobblestone, right? Then in this image also, students, can you see that this part is affected? This is affected, whereas this part of the intestine appears normal. So what I want to show you is the skip lesions. They are very characteristic. You will see a normal intestine with horstrations, and then you will see cobblestones, and then you will see normal intestine, and then you will see cobblestones. Understood? So skip lesions are very, very characteristic. Again, students, in this image, can you beautifully see this cobblestoning? Now, in the MCQ exams, if you get a gross image, something like this, you can mark the right answer. This is the cobblestone appearance. Then, this image shows the creeping fat. Can you see this entire fat is encircling the serosal surface? It oozes out. So, that is called as a creeping fat. What is this? This is the creeping fat. Then again, students, this image, what do you see in this image? This is the normal intestine in which you can see the normal wall. In Crohn's disease, you people can appreciate the cobblestone appearance of mucosa. Then, students, there is a thick rubbery wall. Can you see the wall becomes thick and rubbery? The fat starts wrapping this wall. It starts covering the serosal surface. That is called as a creeping fat. Right? All the things clear? Okay, then the pathologist takes sections from this, and when I see it under the microscope, what do I see? What are the microscopic features of Crohn's disease? One thing is the disease is transmural. It will involve all the layers of the wall, bowel wall. Understood? So that means inflammation is present in all the layers. Sometimes you can see ulcers also. The most important thing about this disease is non-caseating granulomas, right? What kind of a granuloma do you see in this? These are non-caseating granulomas. That is a very, very important point. So which type of inflammatory bowel disease shows the presence of granuloma? Answer is Crohn's disease, right? Now, does all patients of Crohn's disease show a granuloma? No. Robbins say only 35 to 40% will show the presence of a granuloma. Understood? You know what are the features of a granuloma? The most important cell, students? Epithelioid cell. Epithelioid cell is produced from a macrophage. Which is the most important cytokine in granuloma formation? Interferon gamma. Very good. Then what are the other components of a granuloma? There is a collar of lymphocytes and sometimes joint cells. Okay. Next, what else can I see? Sometimes I can see cryptitis and crypt abscesses. Now, what are these cryptitis and crypt abscesses? They are seen in both Crohn's disease and ulcerative colitis, but they are more common in ulcerative colitis. Granuloma is one of the characteristic features of Crohn's disease. Now, what is cryptitis? Any itis means inflammation, right? So, suppose students, this is a crypt. Cryptitis is the presence of inflammatory cells in the crypt lining, right? So, inflammatory cell will be present here. The presence of inflammatory cell here, right? And when lots of inflammatory cells will accumulate in the lumen, I call it as a crypt abscess. Lot of inflammatory cells will accumulate in the lumen of the crypt. We call it as a crypt abscess. What is an abscess? Abscess is a collection of inflammatory cells, right? So what is a crypt abscess? A collection of inflammatory cells in the lumen of a crypt. Simple story, correct? Then students, let me show you a picture of the histology of Crohn's disease. This is the microscopic picture. What can I see? Can you people see these inflammatory cells? What are these? These are basically lymphocytes. And what is one of a very important point of a granuloma? The presence of giant cells. So can you see? All these are giant cells, right? So I can see inflammatory cells and giant cells. This is a granuloma of Crohn's disease. Clear? Then students, this image shows string sign of Cantor. Where do you see? It is seen on the barium scan of Crohn's disease. So that is some extra information that you should know, that the barium scan of Crohn's disease shows the presence of string sign of Cantor. Why? Because in Crohn's disease, students, a very important complication is the formation of a fissure or fistula or a stricture or a sinus. Why will you see the string sign of Cantor? Because this disease is one, it is transmural. It will involve all the layers of the intestine. The second important point is that the ulcer which we see here is deep and knife-like ulcer, right? So because of that, the chance of fissure, fistula, stricture, sinus is much more common in Crohn's disease as compared to ulcerative colitis, right? So here in this barium scan, can you people appreciate this? String-like area. This is called as the string sign of Cantor, which is seen in Crohn's disease. Some extra information. Easy story, students? Okay. Now let us move to the morphology of ulcerative colitis. The 2 points which I've already told you are, the most common site is the rectum and the disease spreads upward from the rectum to the colon. The disease is continuous. So what we see is continuous lesions. We do not see skip lesions. That is why clinical thing which you have to remember, students, surgery can be curative for ulcerative colitis, but not for Crohn's disease. Why? Because in Crohn's disease, the lesions were skipped, right? In ulcerative colitis, the lesions are continuous. So you will remove that part of the colon which has got the lesion. Understood? Easy? Okay, so continuous lesions which are there. Then two other things which you know, it is submucosal. It spreads in a retrograde manner. It spreads in a retrograde manner. And a very important site is the rectum. And then it will involve the colon. Simple story. Okay, now the kind of ulcer which we see in ulcerative colitis is superficial ulcer. Superficial ulcer and broad-based ulcer. It is not deep, it is a superficial broad-based ulcer. Why? Because the disease is submucosal also. Clear? Now, when this disease involves the rectum and spreads upwards towards the colon, it can come towards the terminal ileum also. And in that case, it is called as a backwash ileitis. It is called as a backwash ileitis. When the disease from the rectum spreads upwards to the colon and enters the terminal ileum, it is called as backwash ileitis. Simple. So backwash ileitis, submucosal, ulcer is superficial and it spreads in a continuous fashion. Correct? Now a very important gross point about this disease is the presence of pseudopolyps. That is a very important point which you have to remember. Pseudopolyps are more common in ulcerative colitis. What happens, students? Suppose this is the mucosa, intestinal mucosa. There are protrusions of the mucosa. Why? They are not actual protrusions. They are because of the regenerating mucosa. The mucosa is regenerating, so they will start protruding. They look like a polyp, but that is not an actual polyp. That is why it is called as a pseudopolyp, right? And suppose these are two pseudopolyp, students, sometime their tips will fuse. The tips of pseudopolyps might fuse with each other to form something which is called as the mucosal bridges. It will form mucosal bridges. So the tips of these pseudopolyps will fuse with each other to form something called as the mucosal bridges. These are two important features of ulcerative colitis which you have to remember. Then ulcerative colitis is also called as toxic megacolon. It is also called as toxic megacolon. Why? You know why? Sometimes, students, the bolus of food which is there, because of these pseudopolyps and bridges, it will remain inside the intestine. So, a lot of these toxins are produced by this food. If the food remains in your intestine for a long period, what will happen? It will start producing a lot of toxins and they will dilate the colon, they will modify the colon. That is why it starts looking like a toxic megacolon, distended. Easy story? Okay. Then we come to the microscopy. How will it look like on the slide? 1. The ulcer is more prominent. Ulcer is more prominent. Then I have told you the inflammation will be limited to the submucosa. Below that, things are going to be normal. So, submucosal involvement. Then, cryptitis and crypt abscesses are more prominent. Are you people going to see a granuloma in these cases? No. Granuloma is seen only in Crohn's disease. Cryptitis and crypt abscesses are going to be more prominent, right? Let me show you images, students. In this image, can you beautifully see these protrusions of the mucosa? They are not actual protrusions like a polyp. They are actually pseudopolyps. So, an image like this along with a clinico-pathologic scenario that a 45-year-old woman presents with fever, abdominal pain, and there is diarrhea and the alteration of bowel habits, then a gross specimen of this is given below. And then they can say the female is also showing symptoms of primary sclerosing cholangitis. What is the most likely diagnosis, right? So, this is the specimen of pseudopolyp. The diagnosis there is ulcerative colitis, right? Then, in this image, this is the microscopy. Can you people see this is the mucosa? I can see the inflammatory infiltrate, these blue colored cells, inflammatory cells, till the submucosa. Below that, this part is normal. So, the inflammation is limited only up to the submucosa, right? Next, in this image, I can see a crypt abscess. Can you people see this is a crypt, right? And can you people see that there are lots of these inflammatory cells in the crypt, right? So, what is this, students? This is called as a crypt abscess. Now you understand. Crypt abscess is basically the inflammatory cells in the lumen, and cryptitis is when the inflammatory cells starts going in this area. In this mucosa, if you start seeing this inflammatory cell, we call it as a cryptitis. Clear? Now some extra information here, students, is that remember cryptitis can also be seen in. Cryptitis can be seen in. This can be asked in your MCQ exams. 1. Radiation disease. radiation colitis. Then it can be seen in diverticular diseases, right? So cryptitis can also be seen in these all conditions. Easy story? Now, this is a story to differentiate Crohn's disease from ulcerative colitis. I've already told you Crohn's disease has got skip lesions. So, see, affected, then this is the normal intestine, then affected, then this is normal, then this is affected. Can you do surgery in this case? It's very tough because you can't remove the entire bowel, right? In contrast, you can see ulcerative colitis is continuous. There is no skip lesion. So surgical resection is very easy. You will cut this part of the intestine, the patient becomes all right, right? Now, how will my patient of inflammatory bowel disease clinically present? The patient usually has fever. See, inflammation is there, fever has to be there. Patient has abdominal pain. Patient can have diarrhea. One very important thing in this patient is extraintestinal manifestations. Sometimes these extraintestinal manifestations are an important clue to the diagnosis of various inflammatory bowel disease, right? So here is the list of the extraintestinal manifestations which can be seen in Crohn's disease and ulcerative colitis. So there are dermatologic manifestations. What are these? Erythema nodosum, pyoderma gangrenosum, or oral ulcers, aphthous stomatitis. Hepatobiliary lesion, primary sclerosing cholangitis. This is a very important MCQ, students. The relation of primary sclerosing cholangitis to IBDs, especially it is common in ulcerative colitis. So ulcerative colitis is commonly associated with primary sclerosing cholangitis, and this fact is commonly used in a clinico-pathologic question. Please remember. Then we have fatty liver, autoimmune liver disease, cholelithiasis. Ophthalmologic problems like anterior chamber complications are most common. Scleritis, uveitis, iritis, conjunctivitis, episcleritis, right? And hematological problems like anemia of chronic disease, iron deficiency anemia, clotting abnormalities, thrombocytosis, thromboembolic events. Renal problems like calcium oxalate nephrolithiasis seen in Crohn's disease, and musculoskeletal problems like migratory polyarthritis and sacroiliitis. If you have to remember a few, then please remember erythema nodosum and the skin problems, primary sclerosing cholangitis, then uveitis and iritis you can remember. Then migratory polyarthritis, sacroiliitis and ankylosing spondylitis. This is what you have to remember. These are some extraintestinal manifestations which can be seen in a patient of Crohn's disease or ulcerative colitis. Clear? Now students, this is a very important table which I have created for all of you for the difference between Crohn's and ulcerative. I have tried to inculcate all the clinical differences as well. Please remember this table and revise it 1 or 2 days before the MCQ exams. You can definitely get a MCQ in this. If you're a second year student, then remember this table, because if you're given the question on difference between Crohn's and ulcerative, use this table, right? First of all, site I have already told you. Crohn's usually involves the ileum and cecum. Ulcerative usually involves the colon and the rectum. The HLA which is associated with Crohn's disease is HLA-DR1 and HLA-DR2 is ulcerative colitis. The risk factor for Crohn's disease is smoking. For ulcerative colitis, smoking is protective. Now, this is something which is very different. Smoking can be protective in something. It is protective for ulcerative colitis. Do you know any cancer of female genital tract for which smoking is protective? Endometrial cancer. Correct? Cell. CD4-TH1 cell is involved in Crohn's disease and CD4-TH2 cell is involved in ulcerative colitis. Because it involves a TH1 cell, that is why it leads to the formation of a non-caseating granuloma. Correct? Grossly, if I tell you the differences, skip lesions are present, absent. Cobblestone appearance of mucosa, absent. Deep knife-like ulcer in Crohn's, superficial broad-based ulcer in ulcerative. Pseudopolyps and mucosal bridges are absent in Crohn's disease but present in ulcerative colitis. Thick rubbery ball in Crohn's, whereas toxic megacolon in ulcerative. The disease is transmural in Crohn's and submucosal in ulcerative. All these differences are extremely important. Correct? Next. Granuloma is present in Crohn's disease, absent in ulcerative colitis. Cryptitis and cryptabscesses are much more prominent in ulcerative colitis along with the ulcer. Because of these reasons, the stricture, fissure, fistula, sinuses, all these complications are much more common in Crohn's disease as compared to ulcerative colitis. Now, last point says colon cancer is less prominent with Crohn's disease and more prominent with ulcerative. This is a little controversial story. Robbins still says that Crohn's has lesser chance as compared to ulcerative, right? Both these diseases have increased risk of development of colon cancer, and that condition is called as a colitis-associated neoplasm. Colitis-associated neoplasia. What is a colitis-associated neoplasia? That both of these diseases have increased risk of developing malignancy. Now, earlier books and Robbins always said that UC has more risk, but now latest studies and Harrison is saying that now the risk is almost equal. Correct? Then on radiology, I've already shown you a picture. Crohn's disease shows string sign of Cantor, whereas ulcerative colitis usually shows a lead pipe or hose pipe appearance, right? Antibody which is there in Crohn's disease is anti-Saccharomyces cerevisiae antibody. Ulcerative colitis is P-ANCA positive. This is also a very important point which can be a keyword in a clinico-pathologic question. Along with anti-Saccharomyces, there is another antibody which is coming up for Crohn's disease, that is called anti-flagellin antibody. For Crohn's disease, anti-flagellin antibody is also coming up, right? And which type of ANCA is important for ulcerative colitis? P-ANCA. What are the vasculitis in which you see P-ANCA? Microscopic polyangiitis and Churg-Strauss syndrome. Where do you see C-ANCA? World Cup, Wegener's granulomatosis, right? Revision and correlation. Clear, students? So this is an extremely nice table to differentiate between Crohn's disease and ulcerative colitis. Please remember it along with the images, because any of the images which I have shown you can be given in your exams, right? Now, some recent update which is there is, students, in Robbins 10th edition, there is a disease which is given called as early onset inflammatory bowel disease. As the name suggests, early onset, so they say it can occur in infants and children, right? Due to mutation in genes for epithelial transport, and there is a mutation in IL-1 or IL-10 receptor. So these some data is important because sometimes they can be asked in your MCQ exam. What is responsible for early onset inflammatory bowel disease? Answer can be either IL-1 receptor, IL-10 receptor, or mucosal immunity related genes. Clear? Why is the diagnosis of this entity important? Because then we can give targeted antibodies against the IL-10 receptors, and that gives a very good result in the patient. Clear? Easy story, students. Now, the distinction which I have told you between Crohn's and ulcerative is good, but still there are few cases, students, in which it is very difficult for me to say definitely that this is Crohn's disease or whether this is ulcerative colitis. Those diseases are named as indeterminate colitis. They are called as indeterminate colitis when you cannot say with perfection that this is Crohn's disease or ulcerative colitis. We say this is indeterminate colitis. Correct? The treatment of this entity is very, very controversial and very, very difficult because you don't know what the patient exactly suffers from. Right? With this story, students, I finish off with this topic of inflammatory bowel disease. Let me now test your knowledge and see how much you have understood, because now let us do a lot of these questions. A 32-year-old woman has a 10-year history of intermittent bloody diarrhea. 10 years. That means it has to be a chronic disease. She has no other major medical problems. On physical examination, there are no lesions palpable on DRE, but a stool sample is positive for occult blood. Colonoscopy reveals a friable erythematous mucosa with ulceration that extends from the rectum to the mid-transverse colon. Now, this line is very important. There is a lesion which extends from the rectum to the mid-transverse colon. What do you start thinking in terms of? I start thinking in terms of ulcerative colitis because there is a continuous lesion starting from the rectum to the colon. Biopsies are taken and all reveal mucosal acute and chronic inflammation with crypt distortion, crypt abscess, and superficial ulceration. Superficial ulceration, that means it is a limited disease, right? And there is crypt distortion and crypt abscess. Do you 100% make a diagnosis that this patient has got Crohn's disease? Yes. This patient is at greatest risk for development of which of the following conditions? What is an important complication or extraintestinal manifestation of ulcerative colitis that you have to tell? Acute pancreatitis, no. Diverticulitis, no. Sclerosing cholangitis, yes, this should be the answer. Appendicitis, no. Fistula, no. NHL, no. I've told you that ulcerative colitis has a very high risk of developing primary sclerosing cholangitis, correct? So that is the answer. Good question. Next. Which of the following is a feature of Crohn's disease? Pseudopolyps can be seen, not clearly. Non-caseating granulomas are present, absolutely correct. Backwash may be associated with Crohn's disease, no. Usually associated with ulcerative colitis. So what is the answer? Non-caseating granulomas are present. Correct? A 45-year-old female presented with recurrent episodes of bloody diarrhea which has revealed geographical ulcers on colonoscopic examination. The biopsy was taken and histopathology is shown. What is the most likely diagnosis, right? First option is adenocarcinoma of colon. Does it look like adenocarcinoma of colon? No. I can't see glands which are lined by pleomorphic cells. So wrong answer. Crohn's disease. Does it look like Crohn's disease? Yes. Why? Because can you people appreciate this granuloma in the intestine beautifully? I can see this is the granuloma. So this can be a case of Crohn's disease. Let us see the other options. One other option is NHL. This is not non-Hodgkin's lymphoma or pseudomembranous colitis. No. Best answer here is Crohn's disease, right? So these are the different types of questions which can be asked in your MCQ exam, students. I hope after this module, you will be able to answer all the questions which are related to inflammatory bowel disease, right? So thank you so much, students, and all the best.